more of. As you know, this is our 10th session, and we discussed things like cellular changes, metaplasia, hyperplasia, aplasia, hypoplasia, atrophy, inflammation, healing, immune diseases, hemodynamic disorders. We discussed like a whole bunch of general pathology topics, except for like the main or big topic of cancer. We'll be doing that as our last 3 webinars before I go to Puerto Rico. So what I thought I would do, rather than going through having a microscope lab for every webinar, I saved up a bunch of them. So today I picked out what looked like are about, maybe 25 or so slides. And we're going to be looking at slides in the lab. We're not going to be looking at PowerPoint slides. We'll be looking at real glass slides, super high quality digital files. And now, you could get up off your chair in the auditorium and you could go down to the smelly formalin pathology lab and open up your microscope drawer and hope nobody stole or broke your scope, or hope that your lights didn't burn out, and hope that your eyepieces are in focus, and hope that somebody will be able to sit on the other side of your microscope and show you what you're looking at. Okay, well, that used to be a real problem, but now it isn't, because everybody who is here will be looking through their microscope with me, and I'll be talking to them, and I'll be, yakking. Maybe I'll ask some questions. They will be sometimes rhetorical questions, but anything you want to say when I show you the slides, like if I say, oh, does the cell look dark? You could say yes or no. It doesn't matter. It will help me know if I'm actually showing you the things that I hope to show you. So let's drop the ugly guy, and rather than putting up a PowerPoint, let's actually go to a slide. Now, what I did is I took 1, 2, 3, 4, 5, 10, 15, 20, 25. We've got 34 slides in this 2-hour session. So some of them we may look at very quickly for only about a minute or two. Some of them we may discuss for several minutes. But I think this is an appropriate number. Now, because you are all relatively new to microscopy, when I take all of these examples that I have been talking about over the last 9 webinars, I probably will show normal tissue as well. And rather than this being a histology lab where you have to memorize the names of all those damn cells, we're just going to get a visual feel for the normal features of normal tissues, and then show you some classical examples like acute inflammation, chronic inflammation, hyperplasia, metaplasia for each one. So because I labeled these slides alphabetically, it looks like the first thing that we're going to be looking at is something called ADR. Up there I put ADRE, there I put adrenal. So let's start out by looking at a normal adrenal gland. Okay, and I think what you see now is something that looks like a T or maybe a bird flying, and you can see it has like a darker edge, some connective tissue. Then there looks like that there's something that's very, very, very vascular in the middle, like the adrenal medulla. And then you see some changes within this thicker cortex. So here's what I'm going to do. I think the microscope is working. I'm going to make it a little bit bigger for you because you really can't see cells here. So I'm going to zoom in, let's say, just on this part of the bird's wing. Now I'm going to ask you the question. Can you see the slide? I guess that's a first question I'll ask you. I'm hoping some people will join in and say yes or no, So can you see the slide? Can you see the microscopic slide? Good. I got yeses. Thank you for responding. You could see that at the top, there's some blood vessels, maybe some loose connective tissue. You might call this the adrenal capsule. And then you see a layer here in which the cells look like they're sort of in round clusters, like little glomeruli. Hey, let's call that the zona glomerulosa. And then we're going to move a little bit deeper. where the cells are arranged like palm fronds, or what they call fascicles, or linear streaks. So, this is the zona fasciculata. And then, if we go a little bit further, we can actually go down to an area where the cells are arranged like little reticulations, like in a python. It has kind of that network pattern. It's called reticulated python. And this is the zona reticularis. And then you may remember that GFR for glomerulosa, fasciculata, and reticularis stands for GFR. You can also remember that it also stands for glomerular filtration rate, because right now you're basically resting on top of the kidney. Now, when you go further down, you then see cells that do not look like things, but they have very, very wide open vascular spaces. So, this is the adrenal medulla, where you need access to a lot of wide open spaces. And so, let's just say this is a normal adrenal, and I am going to pop it down again slowly. And I know, for example, that when I pop it down, within a second or two, all of you buzzards see it. I'll pop it down again, and now I'll drag it a little bit. And usually after I drag it within a second or two, everybody sees it. So there's the medulla, very big vascular spaces, but not very thick. And those are your 3 layers. In fact, if you wanted to, you could probably estimate the number of cells in this whole cortical layer. And I can also tell you that if you put an actual measuring stick against it, it'd be about 1 millimeter from here to here. So the normal approximate thickness of the adrenal medulla is about 1 millimeter. And if you looked at it grossly while you're measuring it with your measuring stick, it would be yellow, because all of the cells here are loaded with cholesterol, which is a fat, whether you're making primarily glucocorticoids in the thickest layer, or mineralocorticoids in the subcapsular glomerulosa layer, or sex corticoids, androgens, perhaps estrogen-like compounds in the deepest layer. Okay, so please, I'm going to pop this down a few more times. I want you to use your brain like a little iPhone camera right now, and I'm going to tell you this is a normal full thickness of an adrenal cortex and adrenal medulla. Okay, you don't have to learn the names of every one of those cells either. Just get a good picture for it. That's what I keep telling people in pathology. Don't get hung up on the names of the cells. Just get a good visual understanding, because this is about the most normal adrenal that you will ever see in your life. Okay, now that we had ADR and L, let's look at this now. It looks like we might have another adrenal gland. And look, it looks like, maybe there's some big blood vessels there, but look how thick the cortex is now. So if we would have counted, 100 cells or 1 millimeter, let's say, as the thickness of the previous cortex, this layer looks like it's very, very big. In fact, I'm going to zoom in on a lot of it. Look, it's still very vascular. You have all these blood vessels, but now the cells look like they're really thick, and they're not really thick uniformly. They're kind of thick, almost perhaps in a nodular fashion. So what would you call the cells of the adrenal cortex if they were increased in number? Well, you call that hyperplasia. And this is a classical example of normal hyperplasia. Could this patient have had perhaps a pituitary tumor that was producing ACTH? Yes. Could the patient have had other influences causing this? Yes. I'm going to blow it down again a little bit. Could this patient have been on steroids? The answer is no, because if this patient was on steroids, This external steroids would feed back to the hypothalamus and the pituitary to actually cut off the production of ACTH. So a patient who is hyperadrenal because they're on steroids would have a thin adrenal cortex. A patient who is hyperadrenal because of a pituitary tumor producing ACTH would have a thick adrenal cortex. Okay, I think you're getting the concept here. You know that's not a normal adrenal. Let's go to something I labeled as hypo-PL. So you're probably thinking, well, if the other one was hyperplasia, maybe this one is hypoplasia. And sure enough, look at, you still have these big vascular spaces in the medulla. But take a look at the thickness of this cortex now. Rather than being 100 cells thick, it looks like it could be about 20 or 30. So this is a patient with adrenal cortical hypoplasia. Now see, I got news for you. The slide was labeled as adrenal cortical atrophy, but technically hypoplasia is a better word because atrophy refers to, perhaps smaller cells. This is actually normal cells, but a decreased number. So this is a adrenal in which you see there's only maybe 20 or 30 cells in it as the cortical thickness. So this is adrenal cortical hypoplasia. Now, could this have been a patient who was taking steroids for any reason? Yeah. What if this patient had a small adrenal cortex or a hypoplastic adrenal cortex, but he still was hyperadrenal functionally? Well, it means he's probably on external steroids, isn't it? Because the external steroids that perhaps this patient took was feeding back with a negative feedback mechanism to the pituitary and the hypothalamus to shut off the production or decrease the production of TSH and therefore decrease the growth of the adrenal cortex. Okay, you're doing pretty good so far. I'm going to show you another interesting case here. And these are all things that we have talked about, okay? These are all cases that we have talked about in the last 10 webinars. So if you weren't at any of the previous webinars, you might be a little bit lost. And also, if you had not had any experience at all with histology or normal histology, you may also be lost. So I'm making a couple assumptions here. Number one, you're at the second year medical school level and you probably already taken a histology course. And number two, you have been present or at least understand the concepts that we talked about in the previous 9 webinars. Okay, here's another thing that says ADR. So let's see what that says. Well, once again, it looks pretty thin, doesn't it? But what else do you notice about this adrenal? Well, you can still see it has a medulla because there's some big wide open spaces in the deeper areas. But let's take a look at the cortex. Well, it's thin, but what else do you see? Well, the glands perhaps are not that well defined, but there's a lot of other types of cells here that do not look like glands. Here, I'll kind of zip open this area over here. It looks like there's a lot of chronic inflammatory cells, lymphocytes, maybe even some macrophages. So why would you have a infiltration of lymphocytes within the adrenal cortex? It's something that we talked about. Maybe these lymphocytes are reacting against its own adrenal cortical cells. And that would be a classical example of an autoimmune disease. Remember, we had a big list of autoimmune diseases, and we said that just about any tissue in the body, if it is being attacked or not recognized or not tolerated by its immune system, can result in a chronic inflammatory reaction. So, having said that, how would you like to name this? Okay, look at, there's a whole bunch of lymphocytes here. There's some adrenal cortical glandular tissue that's being infiltrated with these lymphocytes. Here's a really good example right here. I mean, I can show you a lot of good examples. Well, because it's inflamed, you could call it adrenal cortical itis, I guess. Because it's being attacked by its own lymphocytes, you could call that an autoimmune process. Or how about if we call it adrenal autoimmune adrenalitis or autoimmune adrenal corticalitis, or chronic, because most of these inflammatory cells are lymphocytes. It's a chronic, long-standing process. Okay, well, we could call it all those names technically, but the name that most people still call it is Addison's disease. Okay, this is a precise definition of Addison's disease is autoimmune adrenalitis. And remember, we said that with most of the autoimmune inflammatory diseases, it's a chronic inflammatory infiltrate. That's why most of these cells are lymphocytes. How do you like that? So in this case, not only is it attacking the adrenal cortex, but it is making the amount of viable cells of the adrenal cortex greatly reduced in number. So, do you think that clinically this patient might have suffered from a chronic lack of adrenal cortical hormones? Exactly. Okay. This is the disease that they have always classically ascribed to John F. Kennedy. He had Addison's disease also. Okay, is this a patient that might require external steroids if they have this chronic process? Absolutely. Okay, good. We're done with the adrenal. Let's go to probably one of the number one type of tissues the pathologist gets. I think I have only 2 cases here, or maybe 3. Well, I'm not too sure how your visual recollection is, but you can see we have some type of organ here that's round. It has a lumen. It has connective tissue on the outside. There's a lot of these lymphoid follicles in the middle. And then you have this big band here between the serosa and the submucosa, or what we call the muscularis. This is a classical appendix. Now, do you remember one of the main layers of every gastrointestinal tubular organ is the muscularis? So look, you have a bunch of really, really nice, normal, spindly, smooth muscle cells here. Okay, now they look like they're hot dogs because they're cut longitudinally, so you know this is the circular layer. But if you see cells that are cut that look like hot dogs, it could be more of a longitudinal layer. When you cut it in cross section, it looks round. Let's see if we can give you an example of that too. Let's take a thicker area here, like right there. Yeah, these cells here look like they're spindly or longitudinal, or a hot dog that's cut longitudinally. And these cells here look, they're round, okay? And you can see some of the blood vessels in the serosa are a little prominent. I don't know why, but you do know that these muscular layers are not infiltrated by inflammatory cells. If those muscular layers are infiltrated by inflammatory cells. Whoops, I think I screwed that one up. Then you can very, very correctly and rightfully make the diagnosis of acute appendicitis. Look, you can barely see the muscular layer here at all. You can see some mucosal glands. Perhaps you can see a remnant of a lymphoid follicle here. But when you go out to where the muscle is supposed to be, I think you will agree that almost all of these linear, smooth muscle cells, certainly here and even more so here, are infiltrated by inflammatory cells. Now, I'm going to see if you're going to get this one right. I might even ask the question, okay, if this and this and this and this and this and this and this are the inflammatory cells, which are infiltrating the smooth muscle layers. Now here's a smooth muscle cell. Here's a smooth muscle cell. Here's a one. Here's one. Here's one. Probably here's one. If the primary cell of inflammation is a neutrophil rather than a lymphocyte, would you call that histopathologically acute or chronic inflammation? Yeah, somebody already got the diagnosis. This is your classical acute appendicitis. This is what the pathologists see every time a surgeon removes an appendix. And thank you for answering. I appreciate that very much. Let's see if I could say anything else. Yeah, let's go back to the one that we called normal, okay? Because it's going to demonstrate a principle. This is the one that we called normal. And we're going to go back, and you can see that in this case, the smooth muscle layers were not infiltrated by any type of cell. They're just normal smooth muscle cells. But we did comment that some of the blood vessels in the serosa looked like they were a little congested or hyperemic. So could you say that maybe there might have been some kind of process going on here where the serosa of the appendix became a little hyperemic? Well, that could just be possibly due to surgical manipulation. How do you like that? So if I got to tell you a story, I'm not sure if you'll believe it, but you know, there was always a joke among surgeons that if they removed an appendix and they were afraid that the pathologist was going to call it normal, they would rub the surface of the appendix very hard to try to make it look inflamed. Well, it's certainly hyperemic, but in order to make the correct diagnosis of acute appendicitis, the muscularis has to be inflamed, because the outer surface could just be inflamed from some local peritoneal process also. And if you take the mucosa, which we're going to see over here, if that's inflamed, which by the way this one isn't, then it could be inflamed simply because of some inflammatory condition that was in the lumen of the bowel, you know, like inflammatory bowel disease. But look, this is a nice row of columnar glands in the mucosa and a nice little collection of normal lymphocytes. In fact, look, because you even see like lymphoid follicles here. So in the appendix, usually the thickest layer is the submucosa because it's loaded with these giant lymphoid follicles. And this is not an acute inflammatory reaction. Okay, I'm going to ask a question here because we've been cooking pretty good. I want to make sure I'm on the right track. The cases that I'm showing, do you think that they are simple enough, or let's say clear enough, for a person who is not a pathologist to understand? Remember, I'm assuming you're not a pathologist, but I am assuming that you do have some basic knowledge with histology and some basic understanding of these disease processes we've been talking about. And I got several yeses, so I'm very, very happy to hear that. So, the reason why this icon here looks like a picture and the rest of them are just icons is because I could not find in my slide box of, 550 slides, something that showed it this nicely. So rather than the next picture being a real glass slide, it's just going to be a diagram from a Google search, okay? Because I'm going to show you something that you probably can figure out already. You can see there's a uniform layer of cartilaginous cells. Yeah, and they have different names like the superficial, the transitional, the radial zone, the calc. But forget about that part, okay? You're basically looking at a layer of hyaline cartilage that is fairly uniform in thickness, and underneath, I think you could recognize this as bone. In fact, you could probably recognize it as sort of like cortical bone, okay? Or firm bone. So what am I saying here? What I'm saying is that the normal articular cartilage of any joint should be fairly uniform in thickness. And of course, radiologically, when you get an x-ray of your knee or your shoulder or your fingers, that little area there that is not quite as dense as the bone should be uniform. So this is a disease in which we have a uniform and normal number of cells protecting that bone from the joint space, which is up here. So now I'm going to show you something interesting. This is a case now where maybe you could recognize that there is bone again. Yeah, take a look. All of these little spicules are bone. See, they often have a little rim of osteoblasts, around them, and osteocytes in the middle, and marrow in between. But I'm not here to show you the bone. I'm here to show you the cartilage that is covering that joint surface. Look how it's real thin here. It's a little thicker here. It looks like there's almost nothing here. So this is a situation. This is the classical definition of a degenerative disease in which you have a loss of normal number of uniform cartilage cells. This is the earliest change that you see in degenerative arthritis. It's also called osteoarthritis, but I think I like the word degenerative better, and degenerative is probably used more commonly now by radiologists and pathologists and rheumatologists because it is truly a degeneration or a loss or an erosion in number of cells. And of course, if you were a radiologist and you were looking at this in a real patient's knee or elbow or something, you would see a thinning of the joint space because now there is thinning of the cartilage, and it might look at bone was almost connecting directly with bone. How do you like that? In fact, in this case, you also have something, I'm not going to go into this, but you can see there's also such significant thinning of the joint space here and pressure upon the bone that in this area a little cyst has formed because of loss of bone completely. This is a classical picture of a degenerative disease process. We've showed you some classical examples of acute inflammatory diseases. We showed you some examples of autoimmune disease as an inflammatory process. And now we showed you a classical picture of a degenerative process involving the joint. Okay, guess what? I forgot to show you this slide from the appendix, but I think you're going to guess this one right away because it is incredibly easy, okay? Well, look, once again, you can see there's a circular structure here, and there's a lumen. And if I actually blew up this wall and made it thick, you can see once again, there are tons and tons of acute inflammatory cells infiltrating the entire wall thickness of this organ. Now, I know what you're thinking. You're thinking, well, why is he calling them acute inflammatory cells? How do we know those are neutrophils rather than lymphocytes? Well, there's a reason for that. But here, take a look at the majority of these cells. Now I'm going to ask you a question. Do most of the cells that you see in this high power field have a spherical, single, round configuration, like with minimal cytoplasm, like a lymphocyte? Or do most of them have abundant cytoplasm and a lobulated nucleus? So that's how you know almost instantly that these are neutrophils rather than lymphocytes. Also, if they were lymphocytes, there would be very minimal cytoplasm, so it would almost look like these little round balls were like almost right next to each other. Good. That's how the pathologist knows, even before going to high power, like we did here, that these are neutrophils. So what do you call neutrophils that infiltrate a tissue? You call it an acute inflammatory process because the neutrophils. Now, we'll get to that a little bit later, but this is a classical acute appendicitis. But why am I showing you this? Because I've showed you this already. So why am I showing you this again? Well, the reason why I'm showing you this again is because not only do you have these acute inflammatory cells in the wall of the appendix, but here now we are in the fat outside of the wall of the appendix, okay? And not only are we in the fat outside of the wall of the appendix, but you have all these neutrophils again. So what do you call it when you have a big localized collection of neutrophils anywhere in the body? You call it an abscess. So this is a periappendiceal abscess. So why would you have an abscess in acute appendicitis? Well, maybe the appendix ruptured, okay? And now you have contents outside of the actual appendiceal wall. So I'm sure that you've heard of people say, oh yeah, well, the surgeon told me that if he didn't take out that appendix, it would have ruptured and I would have died. Well, believe it or not, even if an appendix has a small abscess around it, it's not necessarily going to be fatal, but it's going to be a lot more serious than if the inflammation is strictly in the wall. Okay, let's go to something that we called, oh, I love this one. This is this is the slide that everybody is going to freak out over because they don't realize that even though it's the most complex of all organs, it's the easiest to recognize histologically. This is a brain. Here is a gyrus of the brain. This little pit is a sulcus. You can see there's little membranes surrounding this cortical surface of the brain. So you know these are meninges. And here is your cerebral cortex. And you know, it has various names for these layers, which we could forget about. But the meninges are nice and loose and delicate, so to speak. And the reason why the cells of the brain or brain tissue in general is the very, very easiest to recognize is because there's only 2 or 3 kinds of cells. You have these big cells, and then you have the little cells. And the big cells are the neurons, and the little cells are the glial cells. So this could very easily be a neuron. It looks like there's a lot more glial cells than there are neurons. And of course, the glial cells that have a halo around them are the oligodendrocytes because they make the myelin. And then the smaller cells could either be astrocytes or microglia. But here, just so as not to disappoint you, let's find a big cell and we'll call it a neuron. Oh, that might be a neuron, okay? That's probably a neuron, that's a neuron, that's a neuron, that's a neuron, that's a neuron. And all these smaller cells are a variety of glia, which support it. Now let's make a big assumption here. let's say you're going to believe me when I tell you this is the world's most normal brain, okay? Because you have your collection of cells, you have a nice delicate meninges. You could probably say, oh, what's that ugly thing right there? Well, it might just be what they call an artifact. This might be a little area where there was a folding of the tissue, or I don't know, but this is a normal brain. I'm disappointed that this artifact is in here with the crushed cells, but this happens, and a lot of times you just have to ignore it. So let's go back again, take a quick view with your eyeballs as an iPhone camera, and you're going to recognize this as a normal brain, cortical, cerebral cortex. And look, there's some bigger vessels out there in the meninges too. So why am I showing you the normal brain? Because I'm going to show you different patterns of brain disease. And I could probably start out with the easiest one, because I'm going to show you some typical boring brain again, like you see here in the Northwest, but then you see this brain substance being interrupted by these red, irregular, jagged streaks. So here, let's go to the Northwest. And once again, you could probably recognize this as normal brain. Most of these are glial cells. Most of these are oligos. I don't see too many neurons here, but overall, there's probably 10 times whoops, recording has stopped. Oh, well, this is not from me. This is from the webinar company. And then when you go back, guess what? We're not recording anymore. I ran out of disk space, but it's still recording at the webinar place, so that's no big tragedy, okay? Let's get rid of this. Now we go to a part of the brain that is interrupted by these red jagged streaks, and I think you could recognize the red as being blood, okay? So this is acute hemorrhage within the brain. Why might a brain have acute hemorrhage? Maybe it was a stroke and the blood is dissecting into the brain. Maybe this was the path of a bullet track. Maybe it was head trauma. Okay, but in all honesty, not knowing anything else about this patient, you can really say that all this represents is acute hemorrhage within the brain. What does that mean? Well, it means you're being honest, okay? And why am I saying acute hemorrhage within the brain? I'm saying acute hemorrhage within the brain because when you look at it, it's basically still mostly just red cells, okay? It's acute blood. If it was chronic hemorrhage, these brain cells may have been broken down and the blood pigments eventually chewed up by the macrophages, and you would see pigmented cells with hemosiderin as chronic hemorrhage. But we're going to call this very correctly acute hemorrhage within the brain, period. Okay, we're not going to get fancy. We're just showing you basic patterns of disease here. How about if we take a look at another brain thing, like here? We have brain again. And look, you can see once again what look like normal gyri and normal sulci. But what about these delicate meningeal cells that cover the gyri and go into the sulci? What can we say about that? Well, what we could say is that the meninges are now infiltrated by inflammatory cells. And I think you figure out right away that most of these cells are lobulated. So I think you probably already can figure out very easily that this is acute meningitis. Notice it involves primarily just the meninges, It doesn't involve the brain too much. But if it did, if it was very severe, then you might tend to call it, rather than just meningitis, you might call it meningoencephalitis. But this is a case of classical acute meningitis, of which most are caused by bacteria. Okay? Now, the reason why I'm saying that is because now we're going to go into a situation here in which we have brain again. And at first you might say, well, the meninges are fine. Look at that. But you say, well, but what about these little areas here that are sort of, let's take a look at that. Now, even though the meninges look fine, you have infiltrations of chronic inflammatory cells or lymphocytes. You see they have practically no cytoplasm around blood vessels. So now we have an inflammatory process going on in the brain, and it looks like it's primarily early or perivascular. But if this inflammatory process got worse or progressed, it might not only involve just the perivascular space, but much of the brain substance as well. So this is an encephalitis, okay, in which the meninges still look pretty good. And remember, in the meningitis, the brain looked pretty good. Now, I know what you're thinking. Your thinking is going along the lines of, if we call this acute encephalitis, then these have to be neutrophils. If we call it chronic encephalitis, these have to be lymphocytes. Well, you know they're lymphocytes, but the problem is this would be called acute encephalitis, even though the primary inflammatory cell is a lymphocyte, or something we associate with being chronic, because it is acute clinically rather than pathologically. Now, that's a very, very important point, because if you're only a pathologist and you see neutrophils, you call it acute, and if you see lymphocytes, you call it chronic. But in this case, even though we're seeing lymphocytes, we're calling it acute. This is not acute pathologically, this is acute clinically, which means the patients may have developed it quickly over the period of a couple of days even. Now, as a rule of thumb, even though we haven't gotten to the central nervous system yet, I want to tell you a very big principle here. Most meningitis are bacterial, and most encephalitis are viral. And there's a good number of exceptions to that, but that's a general rule. Now, I'll tell you another principle. We said that if the meninges were inflamed and it extended into the brain, you might call that a meningoencephalitis. Now, if we said if the brain was inflamed only, you call it an encephalitis. But if the encephalitis also involves the meninges, you could use the combination words again and call it a meningoencephalitis. Okay, good. I am going to, I don't know, maybe I'll take a break, or maybe I'll ask you a question now. We're about half done. Buzzards,